Good morning. The title of my talk is Device Selection for Syncopal Patients. Over the next 10 minutes, I'm going to go over the use of ILRs, pacemakers, and ICDs in patients with syncope. This is my disclosure slide. I have a patent pending for sublingual formulation for hypertension and syncope, and I have an existing patent looking at new methods and systems for the treatment of ventricular arrhythmias. Before we start the discussion on device selection in patients presenting with syncope, I think it's very important that we go over the approach to these patients. If the patient has a serious medical condition, cardiac or non-cardiac, you're going to be admitting these patients. And invariably, you're admitting them not because of the syncope, but because they have a serious medical condition. If the patient does not have a serious medical condition, then the task at hand is to determine what is the suspected mechanism. And this can be cardiac, reflex, or due to orthostatic hypotension. If you suspect from the history that the mechanism is cardiac and the patient has high risk factors, such as LV dysfunction or bifascicular block, these patients are usually admitted for invasive evaluation. And if the evaluation is negative, you should consider ILR implantation in these patients. Another indication for ILR use in patients with cardiac syncope are those who do not have the high risk factors, where you made the determination already to monitor these patients, and their events are infrequent, more than 30 days apart. So this would be another group of patients where ILR use is helpful. There have been several studies comparing ILR to conventional approach in patients with unexplained syncope. One of them in Canada, 2 from the UK, and 1 from France. Most of them were multi-center studies. They included a lot of patients, a significant number. They have excluded patients with LV dysfunction because these patients usually are admitted for invasive evaluation. And invariably, all these studies have shown that the rate of diagnosis with ILR monitoring is greater than the conventional approach. It's important to note that the conventional approach was not standardized in these studies, and certainly the use of tilt table testing was not consistent. In addition to a higher rate of diagnosis, we also know that there is lower cost when you use ILRs. This is a study that was shown in the previous slide. This is the Canadian study by Dr. Kranz and his colleagues, where they enrolled 60 patients with unexplained syncope who had an EF more than 35%. 30 were randomized to monitoring and 30 to conventional. In addition to a higher rate of diagnosis in the monitoring arm, as previously stated, the cost per diagnosis was lower with cardiac monitoring compared to the conventional approach. So with these data, the 2017 syncope guidelines has ILR implantation as a class 2A in patients with syncope that you suspect is of arrhythmic etiology. Once you decide to monitor patients for evaluation of suspected cardiac syncope, it's important that you continue to monitor these patients until you have a diagnosis. This is a study done by Dr. Brignoli's group, published 10 years ago, looking at the rate of diagnosis over prolonged follow-up up to 40 years in patients who received an ILR. So the study included 161 patients. 14 patients received 2 devices and 2 patients 3 devices. What was noted in that study is that 26% of the diagnoses were made after 18 months. And in the waiting period, there were no arrhythmic death. So again, the take-home message from this study is that once you commit to monitoring in patients with cardiac syncope, it's very important that you continue to monitor these patients until a diagnosis is made. Another group of patients that benefit from ILR implantations are patients with vasovagal syncope who are above the age of 40, where you've exhausted everything else. They may not be tolerant to midodrine or Florinef, or they're not candidate to receive drug therapy, and they continue to have fainting spells. So in these patients, there is a role for ILR implantation, and the purpose of monitoring is really to assess their candidacy for pacemaker implantation. And this really kind of came from the issue 3 trial that was published 10 years ago, where patients with established diagnosis of vasovagal syncope who had documentation of spontaneous asystole, either 3 seconds with syncope or 6 seconds or greater without syncope. These patients received a pacemaker. Half of them had the pacemaker turned on, half turned off. And during a 2-year follow-up, the rate of syncope recurrence was basically cut in half in patients with the pacemaker on compared to patients with the pacemaker off, 25% versus 57%. So based on the issue 3 trial, the syncope guidelines, again published in 2017, listed a class 2B indication to have a dual chamber pacemaker in patients with vasovagal syncope. But you have to remember, this is a selected group of patients who are above the age of 40 with demonstration of spontaneous prolonged asystole. And the numbers to remember is 3 seconds with syncope or 6 seconds without syncope. Closed loop stimulation pacing has recently emerged as a effective therapy in patients with vasovagal syncope. As you all know, in the early stages of vasovagal events, there's a high catechol state and patients have increased cardiac contractility. So if you detect that phase and apply AV sequential pacing at high rates, you're going to increase the blood pressure and hopefully abort an event. And that's really what CRS pacing does. And it has been shown to reduce the frequency and severity of syncope in patients above the age of 40 with vasovagal syncope and cardio inhibition. And I want to bring your attention to a couple of studies that I really think you should read if you can. The Spain study and the BioSync. I have the references at the bottom. The Spain study was published in 2017 and BioSync in 2021. In both studies, the method was randomized and included a control arm with sham pacing. And inclusion was limited to patients above the age of 40 with documentation of cardio inhibition during tilt testing. So we talked about the use of ILR in patients with cardiac syncope and selected patients with reflex syncope. Now, the next few minutes, I'm going to talk about pacemaker use in patients with syncope, and in specific, talk about patients presenting with bifascicular block. In our guidelines, we defer to the device guidelines when it comes to indications for pacing in patients with bradycardia. And obviously, this is not the purpose of this talk, so we're not going to go over those details. But again, we're going to talk about patients with bifascicular block. When you look at the device guidelines, patients who present with syncope and they have chronic bifascicular block, pacing is a 2A indication. But it's very important to note that in the guidelines, it's well stated that it's a 2A indication when other likely causes have been excluded. Why? Because you can have bifascicular block and have orthostatic hypertension and reflex syncope. So we don't want to jump and put pacemakers in these patients. EPS followed by ILR if the EP study is negative is a reasonable approach in patients who have chronic bifascicular block and syncope. In fact, both the ACC and the European Society of Cardiology syncope guidelines have this as a class 2A indication. So in these patients, if during the EP study, we document an HV more than 70 milliseconds or evidence of nodal block with rapid pacing or drug challenge, then permanent pacing is indicated. Problem is, patients with negative EP study, a significant portion of them will go on to develop intermittent AV block, up to 32%. So given the low sensitivity of EP studies, some argue, why do an EP study at all and move forward directly with empiric pacing or ILR without EP study? The PRESS study looked at empiric pacing in patients with bifascicular block. They enrolled a bit more than 100 patients, and they were randomized to DDD at the rate of 60 versus DDI at the rate of 30. And they found that at 2 years, there was a significant lower incidence of syncope in the study group, with a hazard ratio of 0.32. However, the incidence of syncope recurrence in patients receiving empiric pacing was 14% over a 2-year follow-up. And that shouldn't come as a surprise because sometimes patients with reflex syncope might present with atypical presentation with no prodromes, and we might have missed also orthostatic hypotension. So again, this is the problem with empiric pacing, is that unfortunately a percentage of patients might continue to develop syncope. The Sprightly trial, led by Dr. Sheldon and other co-investigators, is a randomized trial comparing empiric pacing with ILR-guided approach in patients with bivesical block. The trial has been completed. The manuscript has been submitted and accepted, and it is actually in press in JACC-EP. And I'm sure we're going to learn a lot once the results are available. At present, I think given the limitations with both approaches, meaning ILR-guided, EPS-ILR-guided versus empiric pacing, I think a shared decision-making approach is recommended in the evaluation of patients with syncope and bivesical block. And in our practice, we factor in the age, the risk of monitoring, and of course, patient's threshold for having a permanent pacemaker. The last part of my talk relates to ICD implantation, and the syncope guideline, just like with the Brady indications, they defer to the device guidelines for tachytherapies. And clearly, if you have somebody with a history of syncope and you see them in the ER and they have a run of VT, you know what to do with these patients. But most of the time, what we're faced with is patients presenting with a history that sounds cardiac, and they have the substrate. And what do you do with these patients? Well, most of the guidelines, we have those listed as a 2A indication. So in patients who present with ischemic or non-ischemic cardiomyopathy, if you induce a ventricular arrhythmia during the EP study, that's a 2A indication for ICD implant. Also, if they have significant LV dysfunction, they're going to end up with an ICD. Same for patients with hypertrophic cardiomyopathy, ARVD or ARVC, and cardiac sarcoidosis. If the history sounds cardiac and they have these pathologies, then these myopathies, then they need to receive a device, and it would be a 2A indication. For patients with inherited arrhythmias, some are listed as a 2A, some are listed as a 2B. The 2A would be long QT syndrome and CPVT, but it's important to note that it's a 2A indication to proceed with device implantation only after optimal medical therapy. Beta blockers, namely for both long QT syndrome and CPVT, and with CPVT, sometimes even sympathetic denervation. In patients with short QT pattern or early recall, it's a 2B indication. And it's important to note that with patients presenting with early recall, not only the history has to sound cardiac, but patients must have a family history of early repolarization pattern with cardiac arrest before you consider putting an ICD in these patients. Otherwise, you're going to be putting a lot of ICDs knowing how prevalent early repolarization pattern is in the general population. So we covered basically ILR indications, pacemakers, and ICDs in patients presenting with syncope. I hope you found that information useful. I strongly encourage you to look at the references that we have listed in some of the slides. These are key studies that I hope you will find helpful. And with that, I want to thank you for your attention. Thanks.